Diabetic ketoacidosis. This guideline has been adapted for statewide use with the support of the Victorian Pediatric Clinical Network. Key points. Cerebral edema is the key life-threatening complication of DKA. When managing DKA, hypoglycemia and hypo/hyperkalemia are the other main complications which must be monitored for and treated. Children with DKA are deplete in total body potassium regardless of the initial serum potassium level. Measured serum sodium may be low due to osmotic dilution with glucose. Corrected sodium levels should be monitored. Background. The biochemical criteria for diagnosis of DKA are serum glucose and GT11 mol/L, venous pH and LT 7.3 or bicarbonate and LT 15 mol/L, presence of ketonemia/ketonuria. Children with hyperglycemia, blood glucose level, BGL, and GT11 mol/L, plus/ketosis who are not acidotic can be managed with subcutaneous insulin, c. New presentation. Mildly ill. Hyperglycemic children with altered conscious state who are not acidotic, pH of greater than or equal to 7.3, and have little to no ketonemia may have hyperglycemic hyperosmolar non-ketotic coma. If this is a possibility, insulin should only be given after discussion with local pediatric team and/or pediatric endocrinologist. Precipitants for DKA. Inadequate insulin in a child or adolescent with known diabetes, e.g. missed insulin doses, insulin pump failure. First presentation of type 1 diabetes illness. Assessment. History and examination are directed towards potential precipitants, assessment of severity, and detecting complications of DKA. Assessment of dehydration. Weigh child compared to recent weight if available. Caution. The degree of dehydration is often overestimated in DKA, this may be compounded by peripheral shutdown due to acidosis. Excessive fluid replacement may increase the risk of cerebral edema. Degree of dehydration. Assessment. Mild. Percentage. And LT 4%. Clinical signs. No clinical signs. Assessment. Moderate. Percentage. 4 to 7%. Clinical signs. Easily detectable dehydration, decreased tissue turgor, poor central capillary return. Assessment. Severe. Percentage. And GT 7%. Clinical signs. Shock, poor perfusion, rapid pulse, hypotension. Management. Children and adolescents with DKA should be managed in a unit that has access to laboratory services for frequent and timely evaluation of biochemical variables. Experienced nursing staff trained in monitoring and management of DKA in children and adolescents. A pediatrician, endocrinologist, or critical care specialist with training and expertise in the management of pediatric DKA. Such expertise is not available on site. Telephone advice should be sought from the appropriate specialists. Investigations. Bloods, insert and for when taking bloods. Serum glucose, urea, creatinine, and electrolytes, sodium, potassium, calcium, magnesium, phosphate. Venous gas, including bicarbonate. FBE, hematocrit may be elevated as a marker of dehydration, WCC may be elevated as a stress response. Blood ketones, bedside test, normal and LT 0.6 mol/L. Consider investigations for precipitating cause. If clinical signs of infection, consider septic workup. The following bloods are part of a diagnostic workup for first presentation: T1DM, insulin antibodies, GAD antibodies, ZNT8 antibodies, celiac screen, total IgA, antigliadinib, tissue transglutaminase, TSH and FT4. Collect these bloods with initial blood sampling if practical. Please hand over to admitting team if not done. Urine. Dipstick for ketones, glucose, and FWT. Culture if clinical suspicion of UTI. Consider ECG if potassium results will be delayed. Once DKA is confirmed, the following biochemical monitoring should be put in place to guide ongoing management. These will continue. until resolution of DKA. Hourly BGL, bedside ketone testing. At 2 hours and 2 to 4 hourly thereafter VBG, UEC, CA, MG, PO4. Severity of DKA. Severity of DKA. Mild. Assessed based on the more severe of these parameters. Venous pH, and LT 7.3. Bicarbonate, and LT 15. Moderate. Venous pH, and LT 7.2. Bicarbonate, and LT 10. Severe. Venous pH, and LT 7.1. Bicarbonate, mol/L. And LT 5. Treatment. Goals of treatment. Sections below include correct dehydration, reverse ketosis, correct acidosis, and glucose. Monitor for complications of DKA and its treatment, cerebral edema, hypo/hyperkalemia, hypoglycemia. Identify and treat any precipitating cause, airway/breathing/circulation. C. Blank. Supportive measures and monitoring. Nurse head up. In children with reduced conscious state, monitor airway safety. Consider inserting an NGT to prevent aspiration. Keep nil by mouth until child is alert and preferably until acidosis resolves. Children can be given ice to suck on for comfort. Insert second IVC to use as a blood sampling line. Take initial diagnostic bloods if not drawn with initial IVC insertion. Supplemental oxygen for children with severe circulatory impairment or shock. Cardiac monitoring for assessment of ECG changes related to potassium levels, hyperkalemia, peak T waves, widened. QRS, hypokalemia, flattened or inverted T waves, ST depression, PR prolongation. C. ECG interpretation. Consider antibiotics for febrile children after obtaining appropriate cultures. Consider urinary catheter for children who are unconscious to allow strict monitoring of fluid balance. Weighing nappies can be used for strict fluid balance for children who can't urinate on demand. Timeline of monitoring and management. Timeline. Presentation. Observation/investigation. Assessment and ABC. 4 access and initial bloods including VBG. Weigh child. Start rehydration fluids. Nurse head up. Document passage of urine, ask child to void. Management, 0.9% sodium chloride plus/potassium. Timeline, 1 hour, observation/investigation. Fluid balance, vital signs. Neurological observations, BGL and bedside ketones. Management, start insulin infusion. 2 hours. Fluid balance, vital signs, neurological observations, VBG. VBG and bedside ketones. UEC, must check serum potassium within 1 hour of starting insulin. Infusion. Serum calcium, magnesium, phosphate. Adjust fluids if required based on glucose and electrolytes. 3 hours. Fluid balance, vital signs, neurological observations. BGL and bedside ketones. Adjust fluids if required based on glucose. 4 hours. Fluid balance, vital signs, neurological observations. VBG and bedside ketones. UEC. Serum calcium, magnesium, phosphate. Adjust fluids if required based on glucose and electrolytes. 5 hours. Fluid balance, vital signs, neurological observations. BGL and bedside ketones. Adjust fluids if required based on glucose. 6 hours. Continue the following. Hourly. Fluid balance, vital signs, neurological observations. BGL and bedside ketones. Continue the following. 1 to 2 hourly. BGL. Continue the following. 2 to 4 hourly. UEC, VBG. Serum calcium, magnesium, phosphate. 1. Correct dehydration. Children with DKA will be dehydrated. Clinical estimates of fluid deficits are subjective and often inaccurate, thus most children can initially be commenced on the mild or moderate fluid rate, see below. A 10 ml/kg 0.9% sodium chloride bolus can be given to children who are tachycardic with delayed central capillary refill. This should be followed by a reassessment. Acidosis results in poor peripheral perfusion, so use central capillary refill with vital signs to assess response to fluids. Initial fluid replacement. Commence rehydration with isotonic fluid, e.g. 0.9% sodium chloride. Ask child to pass urine or remove nappy. Add 40 mol/L potassium chloride to this fluid if the serum potassium less than or equal to 5.5 mol/L and the child is passing urine. If anuric or serum potassium and GT 5.5 mol/L, do not add potassium to the fluids until this has resolved. Keep nil by mouth until child is alert and acidosis has resolved. Children can be given ice to suck on for comfort. Intravenous or oral fluids that have been given at another facility may need to be factored into the assessment and calculation of fluid deficit and replacement. If the child has received more than 20 ml/kg, discuss the adjustment of fluids with the consultant. Initial fluid rates, ml/hr, based on degree of dehydration. Weight: mild/nil dehydration, moderate dehydration, severe dehydration, ml/hr. Fluid adjustments. Frequent monitoring of electrolytes, glucose, and osmolality will guide fluid composition and infusion rates. Fluids containing 0.9% chloride should be continued for at least the first 6. The three key parameters to monitor and manage are glucose, potassium, sodium. Osmolality can be calculated using the following formula. Osmolality equals 2x, serum sodium plus serum potassium, plus glucose plus urea. Glucose. BGL will decrease rapidly during initial rehydration/volume expansion and continue to decrease once the insulin infusion is started. Once BGL is less than or equal to 15 mol/L, change fluids to 0.9% sodium chloride with 5% glucose and potassium chloride, maximum 60 mol/L. As required, aim to keep the BGL between 5 to 10 mol/L. If BGL falls below 5 mol/L or is falling rapidly, and GT 5 mol/L/hour, in the range between 5 to 15 mol/L and the child remains acidotic. Insulin. Increase the glucose content to 10%. Insulin infusion rate should only be decreased if BGL continues to fall despite glucose concentration of 10%. Potassium. Children with DKA have a deficit of total body potassium, however serum potassium levels may be normal, high, or low. Treatment with insulin will shift potassium to the intracellular space rapidly, resulting in hypokalemia if potassium is not replaced. Start potassium chloride at a concentration of 40 mol/L, increase to a maximum 60 mol/L if required to maintain serum potassium in the normal range. Once insulin is commenced, a repeat serum potassium should be measured within 1 hour and 2 to 4 hourly thereafter. Sodium. Measured sodium is depressed by the dilutional effect of hyperglycemia. Corrected sodium can be calculated with this formula. Corrected sodium equals measured sodium plus 0.3x, glucose 5.5, mol/L. i.e. 3 mol/L sodium to be added for every 10 mol/L of glucose above 5.5 mol/L. 0.9% sodium chloride with glucose and potassium chloride, maximum 60 mol/L, as required, should generally be used for the duration of 4 rehydration. If a hypotonic solution is later thought to be required, discuss this with the pediatric endocrinologist on call. The sodium chloride content should be at least 0.45% or greater. If measured sodium does not rise as the glucose falls during treatment, or if hypoatremia develops, this usually indicates excessive fluid correction, which may increase the risk of cerebral edema. Extremes of corrected sodium should be discussed with a senior doctor early. 4 fluids can be ceased once pH and bicarbonate have normalized and the child is able to tolerate oral intake. This usually coincides with Insulin being changed to subcutaneous injections. Phosphate. Phosphate replacement is rarely required, due to intracellular phosphate stores usually being adequate. If phosphate levels drop below 0.32 mol/L or symptoms of hypophosphatemia are present, for phosphate replacement may be required. Calcium levels will need to be monitored if 4-phosphate is administered. 2. Reverse ketosis and correct acidosis. 4. Rehydration should be commenced prior to starting an insulin infusion. Insulin. To make up the insulin infusion, add 50 units of clear/rapid-acting insulin, actropidhum or Humulin R, to 49.5 ml of 0.9% sodium chloride to form a 1 unit/ml solution. Initial insulin infusion rates. Children with DKA should generally be commenced at 0.1 units/kg/hour. A reduced infusion rate of 0.05 units/kg/hour should be used for children undergoing inter-hospital transfer, limited access to biochemical monitoring, children less than 5 years old, children with BGL and LT 15 mol/L at the time of commencement of the insulin infusion. Practical points. Insulin infusion can be run as a sideline with the rehydration fluids via a 3-way tap provided a syringe pump is used. Ensure the insulin is clearly labeled. Adequate insulin must be continued to clear ketones and correct acidosis. Aim to keep the blood glucose between 5 to 10 mol/L by increasing the fluid glucose concentration to 10% before adjusting the insulin infusion rate. Changing from an insulin infusion to subcutaneous insulin can be changed when child is alert and metabolically stable, pH and GT 7.3, HCO3 and GT 15. Best time to change to subcutaneous insulin is just prior to a meal. Discuss the dose and regimen with the consultant on call. Continue the insulin infusion for 30 minutes after the first subcutaneous injection of rapid-acting insulin, then cease. 3. Monitor for complications of DKA and its treatment. The most important complications of DKA and its treatment are cerebral edema, hypoglycemia, hypo/hyperkaliemia, hypo/hypernatremia, aspiration, if obtunded. Cerebral edema. Background. Some degree of subclinical brain swelling is present during most episodes of DKA. Clinical cerebral edema occurs suddenly, usually between 6 to 12 hours after starting therapy, range 2 to 24 hours. Mortality and severe morbidity rates are very high without early treatment. If cerebral edema is suspected, this should be immediately discussed with a consultant. Risk factors. First presentation: diabetes. Long history of poor control. Age and LT 5 years old. Signs. Early: headache, irritability, lethargy, vomiting. Later: depressed consciousness, incontinence, thermal instability. Very late: bradycardia, increased BP, respiratory impairment. Treatment: nurse head up, reduce fluid infusion rate by 1/3. Contact pediatric, infant and perinatal emergency retrievals on 1300 137 650 kH14. Give mannitol immediately if cerebral edema suspected. Do not wait for cerebral imaging. Mannitol 20%, 0.2 g/ml, dose, 0.5 g/kg for over 20 minutes, dose range, 0.25 to 1 g/kg, repeat if no improvement within 30 to 60 minutes. Discuss with consultant on call and liaise with intensive care or pediatric retrieval service to discuss transfer. Hypoglycemia. A BGL of and LT 4.0 mol/L should be treated with additional glucose as below. 2 ml/kg 10% glucose for bolus, repeat if required, and change rehydration fluids to include 10% glucose with 0.9% sodium chloride, with potassium chloride, maximum 60 mol/L, as required. Do not discontinue the insulin infusion. If hypoglycemia occurs despite use of 10% glucose in preceding 2 hours, decrease insulin infusion to 0.05 units/kg/hr, 0.03. units/kg/hr if previously on 0.05 units/kg/hr. Continue with 10% glucose in fluids until BGL is stable between 5 to 10 mol/L. Oral treatment for hypoglycemia can be used if pH greater than or equal to 7.3 and the child is alert and able to tolerate oral intake. Use 4 to 5 jelly beans, or a serve of juice, 60 ml, 5g carbohydrate, for children and LT 25 kg, 120 ml, 10g carbohydrate, for children greater than or equal to 25 kg. Recheck BGL after 15 to 20 minutes and give another serve of juice or jelly beans if BGL still and LT 4.0 mol/L. If oral treatment has been used, discuss timing of transition to subcutaneous insulin and oral diet with endocrinology/consultant on call. 4. Identify and treat precipitating cause. Assess for underlying infections and consider antibiotics after obtaining relevant cultures if appropriate. Overall, infective precipitants are uncommon. In children with known T1DM, the most common cause of DKA is omission or significant reduction in recent insulin doses. Other things to consider. Persisting acidosis. If the acidosis is not correcting, consider the following. Insufficient insulin to switch off ketosis, check insulin delivery. Inadequate rehydration. Sepsis. Hyperchloremic acidosis, secondary to 4 fluids. Salicylates or other substances that cause metabolic acidosis. Rarely required. Bicarbonate. Discuss with consultant endocrinologist prior to administration. Only appropriate for children with life-threatening hyperkalemia or requiring inotropic support. May cause paradoxical CNS acidosis. Associated with increased risk of cerebral edema. Sodium bicarbonate dose, mol, equals 0.15 x body weight, kg, x base deficit, mol/L. Administer for over 30 to 60 minutes with cardiac monitoring. Reassess acid-base status and beware of hypokalemia. Consider consultation with local pediatric team for all children with DKA. All newly diagnosed diabetes mellitus, hyper/hypoatremia. Consider transfer when intensive care monitoring is recommended for children and LT 2 years of age. Coma, cardiovascular compromise, seizures, signs of cerebral edema, severe acidosis, pH and LT 7.1 or HCO3 and LT 5. The care required is beyond the level of comfort or resources of the local hospital. Children and adolescents with DKA should be managed in a unit that has access to laboratory services for frequent and timely evaluation of biochemical variables. Experienced nursing staff trained in monitoring and management of DKA in children and adolescents. A pediatrician, endocrinologist, or critical care specialist with training and expertise in the management of pediatric DKA. Such expertise is not available on site. Telephone advice should be sought from the appropriate specialists. For emergency advice and pediatric or neonatal ICU transfers, call the Pediatric Infant Perinatal Emergency Retrieval Service, 1300. Information specific to RCH and Monash Children's Hospital. Children with DKA should be discussed with the pediatric endocrinologist on call.